Good day, everyone. I appreciate you guys showing up here today. My name is Kelly Cox, and I am the moderator for today's fantastic program put on by the International Myeloma Foundation. While some of you are waiting, you see some things that we do there. One of the things I'd like to talk about is all of our publications. We have a publication for every aspect of multiple myeloma that's going on out there. And the best part about it is you can download those publications off our website at myeloma.org. Today's program is not necessarily about me, and I want to tell you about who's speaking. I am the Senior Director of Regional Community Workshops. We're going to have Myeloma 101 and Frontline Therapy, two very important talks. If you hadn't listened to them before, don't worry, you'll get something different from Dr. Edward Stadtmauer, MD, University of Pennsylvania. After which we'll have a question and answer with the panel, and that will be Dr. Ed and Dr. Luciana Costa and Daniel Verena, a member of our Nurse Leadership Board. These folks are going to do a great program twice throughout the morning for you, and I think that you'll find that invigorating and educational. None of this would be possible without our generous sponsoring from Amgen, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Oncopeptides, Takeda Oncology. Now, get your number 2 pencil out, your legal pad, because we're going to go over a lot of things. And remember that this is here for you. We will have a follow-up video replay of our program shortly after this one. This is completed. The other part that's incredibly important to us is your feedback. This is my 113th regional community workshop, and none of these programs would be as fine-tuned as they are without the participation of you as a person watching it with your feedback. You'd be surprised what we hear and what we gather from it and how we apply it. The final thing that I'll discuss here is that these are quick. You'll see it goes Myeloma 101, Frontline Therapy is about 35 minutes, then there's question and answering. Then we'll have a little meditation break in the middle of this and a stretch break. Then we go right into relapse therapy and clinical trials. Then we go into how to manage myeloma symptoms and side effects, a great talk about you personally, how it affects you personally, and a question and answer with the panel. We should be done about 12:15, 12:30. So all that time you're giving me today, I'm incredibly grateful for. With that all being said, I'd like to go to our first doctor who's going to be discussing Myeloma 101 and Frontline Therapy, Edward Stadtmauer, MD, from a little school out there in Philadelphia called the University of Pennsylvania, a big school out there. And we are thrilled, and I'm thrilled personally to have you be speaking today, Ed. So without further ado, please take it away, Ed.
Kelly, thank you so much. It's really a pleasure to be here and to participate in all the great work of the International Myeloma Foundation. And hello to everyone in the Bay Area. I love that area and wish I could be there with you. And there is a football game going on right now at the University of Pennsylvania. Penn has been very poor in football this year, but hopefully they'll win this game. Yeah, so in the next 5 hours, I will talk to you about Myeloma 101 and Frontline Therapy. Obviously, it's really important to have a groundwork for what we're going to talk about the rest of the day. Next slide, please. And you know that it takes a village in order to care for someone with myeloma, starting with the caregiver, but you have oncologists and advanced practice providers, and then all of the nurses in the clinic, along with the primary care physician, who is usually the one who has picked up this disease, and social workers, and so much. And it really is a team effort that is designed in the end to get the best quality of life and outcomes for our patients with myeloma. Next slide. So what is myeloma? Plasma cells. Plasma cells are normal cells in the bone marrow that make the antibodies that fight infection. And you know, we've been hearing so much about antibodies, particularly in the era of COVID. You know, this is one of the primary ways that our body fights infection. And normally you have 1 million different plasma cells, so you can make 1 million different antibodies, so you can fight off any infection that you might be exposed to. But for whatever reason, sometimes a plasma cell will get screwy, some mutation or something, that instead of making millions of different antibodies, the plasma cell proliferates, and you make the same plasma cell, and so you make a predominance of one useless antibody, and that is the monoclonal protein that we find in the blood and the urine. This is an antibody or a piece of an antibody, and you can see in the diagram, this is the way we think of antibodies, that they have heavy chains and light chains. They have two protein components. And the light chains we hear a lot about, that's the kappa or the lambda, that those light chains themselves might just be floating around. And the heavy chains are the primary name, the IgG and the IgA and the IgM. Those are the heavy chains. And these are what are produced by those abnormal plasma cells. Next slide, please. Now, multiple myeloma is a disease of the bone marrow and the blood. So it's and it actually is the first or the second most common cancer of the bone marrow, though you don't hear about it as much as leukemia or lymphoma. There's over 30,000 cases in the United States every year, and over 130,000 people are living with multiple myeloma in the United States. It represents only about 2% of all new cancer cases, and this is a disease of adults. The average age is somewhere in the neighborhood of the late 60s, early 70s. Though we all have young patients in our practice, the youngest person I knew of, though didn't take care of, was 16, and my youngest patient was 24. So it really does span all of the ages of adulthood. Next slide. Now, in addition to the bone marrow and the plasma cells, what is in some ways sort of different about this disease is it really is what we call a systemic disease. It has effects throughout the entire body. Of course, in the bone marrow is the primary organ that makes blood cells. And so as that bone marrow fills up with these abnormal cells, it crowds out the good guys. And so people can become anemic and tired, or have a low white count, make them more susceptible to infection, have a low platelet count, making them more susceptible to bleeding, and you can have fatigue. But in addition, as this protein, these antibodies or pieces of antibodies that are floating around, they tend to be ultimately excreted by the kidneys. And sometimes those proteins can gum up the kidneys. And so people can have kidney dysfunction or kidney failure from this disease. And that's why we're always telling people, and I'm going to tell everyone who's listening, is make sure you're keeping yourself well hydrated and avoiding things that we sometimes give patients that can hurt their kidneys, like the intravenous dye of CAT scans, Motrin and Aleve, and non-steroidal anti-inflammatory medicines or certain antibiotics can hurt the kidneys. But keeping yourself well hydrated is probably the most important thing. And then the number 3 big thing is there are also chemicals that are squirted out by these abnormal plasma cells that stimulates normal cells in the bones to eat holes in the bone. So painful, crumbly, lytic bone lesions, osteoporosis, so a propensity for crumbly bones, and leaching out of calcium and high calcium levels all can occur in this disease. Next slide. So really one of the key aspects of myeloma is diagnosing it. And so it's so important and to raise awareness of this disease as part of the differential diagnosis of so many different problems. And that's why our primary care physicians are so important. And thank goodness, I think the awareness of multiple myeloma has over the last decades has really been increased substantially. And I think most physicians are aware and are thinking about it when they see these abnormal blood tests or abnormal bone issues. But then, and they can usually initiate the workup, but then usually going to an oncologist or a specialist of multiple myeloma is important. Of course, physical examination and taking a good history is important, doing some blood work, doing some x-rays, but of course the dreaded bone marrow aspirate and biopsy is usually the test that we do to really pin down the diagnosis. In other words, we like to see the abnormal plasma cells at an elevated amount before we really make the diagnosis. And an elevated amount in general is if more than 10% of the bone marrow are these abnormal plasma cells, that gives you the diagnosis of a malignant plasma cell disorder or myeloma. Defining what stage or what aspect of the disease is really important for treatment planning. And as you know, there's a whole distribution of plasma cell disorders going from what we call the monoclonal gammopathy of undetermined significance, or where there's an abnormal protein in the blood or the urine, but no other manifestations of disease. And in fact, if you do a blood test on the population above age 50, 1 to 3% of the population will have some abnormal protein. And fortunately, if you follow these people for the next 30 years, 2/3 of the people will never develop anything. So that's why we frequently call this a benign monoclonal gammopathy, but it does deserve observation. Then there's smoldering myeloma, where we have the abnormal plasma cells in the bone marrow, and we have frequently an abnormal antibody floating around, but no other manifestations of the disease. Then active myeloma is when you actually have these manifestations that I just talked about: bone disease, kidney disease, etc. And then there's this uncommon but appears solitary plasmacytomas, where there's just one lump of abnormal plasma cells. And that is one of the settings that's important to really examine and really look for other areas. And if you truly have a solitary plasmacytoma, that's one of the areas where sometimes just radiation therapy can cure the disease, and it can never come, and it may never come back. We always give a name to everyone's myeloma, and it's usually based on what antibody is seen and what light chain is seen. So an IgG kappa myeloma versus an IgA lambda. In a very small number of patients, now it's less than about 5%, there's a setting called non-secretory myeloma, where the plasma cells are so screwy that they can't even make any antibody or even piece of an antibody. And then, once you make the diagnosis based on which aspect of the disease you have, MGUS, smoldering, etc., you then come to a treatment and supportive care plan that usually requires some therapy and some monitoring. Next slide, please. You'll hear frequently about these various tests that are conducted. The blood tests are almost always a blood count, a complete blood count, or a CBC, which is the hemoglobin, the white count, the platelet, a complete metabolic panel, which is blood chemistries, the kidney function, liver function, electrolytes. Very important for our staging purposes, not maybe so much for treatment purposes, is a blood test called the beta-2 microglobulin. It's one of the tests that correlates very well with how rapidly the myeloma cells are growing. And people who have a high beta-2 microglobulin are potentially at a more rapid growing phase than those who don't. It's very important, but this is not a test that we tend to monitor for the long haul. It's very important at the beginning, so to get that blood test. And then the ones that we follow the most are the serum protein electrophoresis. That's what we call the SPEP. That's the most accurate test for the amount of monoclonal protein that someone has, but it's not always a positive test though. And then the serum-free light chain blood test, which has the kappa and the lambda, and ratios of that are very important. Additionally, we like, at least at the beginning, to do some urine tests, usually a 24-hour urine collection, and see if there is this abnormal protein in the urine. There's a subset of patients where there's nothing in the blood, but it's only identified in the urine. And so that's really important to identify early in the course of the disease. And then finally, imaging. Since this is a disease that can either have lumps of disease, what we call plasmacytomas, that might not be obvious by physical examination, or have holes and potentially imminently breakable lesions, it's very important to get imaging. There is not such a thing, though, as the best test. Each test gives us different information. The X-ray test, or what we call the complete bone survey, is very good at showing us clinically important holes in the bones, whether something's imminently going to break or not. But it's not very sensitive. People can have small lesions that won't show up on the X-rays. An MRI is very sensitive, but is not. It's difficult sometimes to get a whole body MRI. CAT scans, and particularly PET CAT scans, where they inject some radioactive sugar, is a helpful test to see whether the lumps are active. But there is a thing called a whole bone CAT scan, which perhaps is even the best test to identify bone lesions as a sensitive test, but is not always available at all of our centers yet. Next slide. We talked about the bone marrow biopsy. The most important part of the bone marrow biopsy is giving us the diagnosis. And as I told you, greater than 10% involvement of plasma cells versus all of the other cells in the bone marrow diagnoses multiple myeloma. And in patients who have smoldering myeloma and there's greater than 60%, that actually diagnoses active myeloma nowadays, even if there aren't more manifestations of the disease. But probably the second most important thing from a bone marrow biopsy is chromosome analysis. And there's a classic chromosome analysis called karyotyping. That is not very sensitive in multiple myeloma. The more useful test is called the FISH test, or the fluorescence in situ hybridization test. That test, which is now routinely done, is the one that tells us the most about breaks in the chromosomes and translocations in the chromosomes. And depending on what those are, it can sometimes help us with prognostication. So far, it's not that helpful in terms of directing our therapy, however. But we're very hopeful that we'll get more and more targeted therapies for that. Next slide, please. So we put all of this stuff together: imaging, blood tests, urine tests, bone marrow analysis, And that gets us to what's the state of the disease and starts allowing us to figure out what's the best treatment. Next slide, please. We talk sometimes about staging in myeloma, and the current staging that's probably the most important and used is called the Revised International Staging System, the RISS. I must admit, though, I'm not a big, frequently patients will ask me, what's my stage? When we think of staging, we're primarily thinking of like breast cancer or colon cancer, where obviously low stage is treated by surgery, pluck it out, and higher stage requires chemotherapy and is not and is frequently not curable in those cancers. In myeloma, by definition, the disease is throughout our body in the bone marrow. So the staging doesn't really define much about it. I say myeloma is more like pregnancy. You're either pregnant or you're not, and you're pregnant. But there are some aspects that are helpful in defining what in maybe focusing us on therapies. And most importantly is that beta-2 microglobulin, another blood test called the albumin, and then the presence or absence of various chromosomal abnormalities. Next slide, please. And so we characterize myeloma really in two major categories: standard risk, which is about 80% of the patients, and high risk, which is about 20% of the patients. And the chromosomal abnormalities tend to be these translocations between, incidentally, the 14th chromosome is the chromosome that codes for the heavy chain. And so it's recombinations or abnormal combinations of other genes with that heavy chain gene that leads to activation of these plasma cells in an abnormal way. So the 1416 translocation, the 1420 translocation, a deletion 17p, a +1q, these are the ones that we think of the most as higher risk abnormalities. And if you have those abnormalities plus a high beta-2 microglobulin, low albumin, those bring us into that high risk phase. Next slide, please. So it's really important for everyone to at least have a discussion about tell me about my disease, and it's very important. I think the best care for someone is the combination of of your local oncologist. Plus, it's good to have someone who is a specialist in multiple myeloma and having that team care for you as part of this. Next slide, please. Next slide. I'll go to the next slide. So I gave you, I think that if you really were able to, in retrospect, look at everybody, you would see that there is an evolution from normal plasma cells to MGUS, to smoldering myeloma, and then to active myeloma in everyone's sort of history. And then for many people, you can have very long and good remissions, but ultimately for the majority of patients, the disease relapses, and then you need other therapies. And Luciano is going to speak most about the relapse disease. Next slide, please. So again, MGUS just has the presence of abnormal protein. Smoldering myeloma is when you have the presence of abnormal protein plus up to 60% and between 10 and 60% abnormal plasma cells. And then we define, and then active myeloma is when you have these, what we call CRAB criteria, these these the bone lesions, the kidney problems, the low blood counts, or certain aspects of smoldering myeloma, we now, as a community of myeloma doctors, have decided we're going to call active myeloma. And that's if you have more sensitive X-ray findings like an MRI or a PET CT that shows more than one lesion, or if you have greater than 60% plasma cells in the bone marrow, or if there's greater than a 100-to-1 ratio of kappa to lambda or lambda to kappa. Though I must admit that ratio aspect of these criteria, if that is the sole reason that someone's considered a higher risk smoldering myeloma, will frequently be something that will just cause us to watch it more closely, but not necessarily initiate therapy. But because we now consider a subset of patients who were considered smoldering myeloma active myeloma, we now have a newer group of patients who are high-risk smoldering myeloma. And though I don't have it here, that's the group that we frequently think of 2022, which is 20% or more plasma cells in the bone marrow, 20-to-1 ratios of a light chain, and an M spike greater than 2. And with 2022, it has maybe a 50% chance of progressing in a couple of years to active myeloma. And so more and more we're considering whether that's a group of patients who should be treated. Next slide, please. So the current treatment approach for these non-active myelomas is MGUS, definitely just monitoring. And in fact, with both MGUS and with smoldering myeloma, I'm actually not one to even define those conditions until I've monitored someone for about a year. And so you want to closely monitor, because you never know if you just happen to catch someone with active myeloma really early, or whether it really is a benign smoldering condition. And so I watch those people at least every 3 months for the first year. And then if a year later there has been no change, then I'll say, okay, this is MGUS or this is smoldering. And then you continue to monitor, but you can be more confident that there should be an indolent outcome for those patients. Next slide, please. Next slide, I think. Now, one thing that you're going to hear more and more about is MRD testing, minimal residual disease testing. And all that means is, when we do a bone marrow biopsy, you start off with greater than 10% abnormal plasma cells. Then someone goes into remission, which is defined as a significant drop in the amount of abnormal protein, or complete remission when the abnormal protein has completely disappeared. And you do another biopsy and you see there's now less than 5% abnormal plasma cells, or hopefully no abnormal plasma cells. And that's called complete remission. The problem is that our tests are not that sensitive, that even with a bone marrow biopsy that shows complete remission, there still can be 1 million cells or more in the person's body. And so we have more sensitive testing, one test called flow cytometry, another test called PCR, et cetera, that can now detect whether you have 1 in 1 million abnormal cells. And so we consider somebody who has more than 1 in 1 million by that test to be MRD positive, and less than 1 in 1 million to be MRD negative. And so more and more we're using that as both a goal, let's get someone to MRD negativity, and also as a marker of whether, and to see whether we can make treatment decisions based on that. So you'll hear a lot about this test. Next slide, please. So I'm going to spend the rest of the time, maybe the next 5-10 minutes, to talk about what's the treatment of active myeloma. And one of the things that you're going to hear much about is transplant eligibility. Are you a candidate for transplant? And let me step back a second and just help at least give you some my spin on transplant. So people think of a bone marrow transplant as sort of replacing a sick bone marrow with healthy bone marrow. And that's what we do in allogeneic transplant or donor bone marrow transplant for leukemia and lymphoma. That's really not the philosophy that I have with autologous transplant for multiple myeloma. In autologous transplant, the philosophy is there's a medicine called melphalan that has been used for the last 70 years and is an excellent anti-myeloma medicine. And that even a patient who's in a beautiful remission after initial therapy, as we've talked about, still have some minimal residual disease. And obviously those cells must be somewhat resistant to the medicines that they had already. So the philosophy that I have of high dose melphalan and a stem cell transplant is I want to kill those nasty cells that are still left with a different medicine. And it just so happens that the best way of giving melphalan, that medicine, is one big kaboom rather than little doses over time. And the problem is when you give one big kaboom, it damages the bone marrow. So you got to first take out bone marrow, freeze it away, then you can give the kaboom of melphalan, and then you give the transfusion of the stem cells as a rescue, as supportive care to get you through that. And so at least philosophically, I think of it as an important aspect of the care of patients with myeloma. So the question is, who is eligible for that transplant? Well, obviously you got to be healthy. Heart, lung, kidney. You want to be walking and moving, what we call good performance status. And we often talk about age, but I don't consider age absolute. I mean, especially since we do a thing called risk-adapted dosing of high-dose melphalan. So we give a different dose, a lower dose, to people who are over the age of 70 or under the age of 70. So in the United States, centers generally use full dose up to age 70, but then use a lower dose, but it gives a similar outcome. So, and a final thing I wanted to say is the decision about should you do a transplant or whether a patient's eligible for a transplant is usually not made at the time of the initial diagnosis. It's after you've gotten some therapy, then you can really make a decision if they're responding and tolerating it. Next slide, please. So this study sort of gives us, I think, the current approach to the transplant eligible newly diagnosed multiple myeloma patient. The initial therapy, the standard of care currently, is a 3-drug combination called Revlimid, Velcade, and Decadron, or RVD or VRD. And we usually start that for a number of cycles. And it's given as pills, 3 out of every 4 weeks, shots once a week, and this dexamethasone therapy. Velcade is what we call a proteasome inhibitor that's given as a subcutaneous injection. And this was a big study that asked the question, is what's the role of, what's the best timing of giving the high dose melphalan and the stem cell transplant? And so in this study, people got the initial therapy, every patient got stem cells harvested, and then half of the patients went on to a couple more cycles of RVD and then Revlimid maintenance therapy. And the other half went on to a slug of high-dose melphalan, stem cell transplant, and then Revlimid maintenance therapy. And this study is still ongoing. It's been monitored now for 8 years. And what it clearly showed was that the people who got the high-dose melphalan and the transplant had significantly longer durations of remission. We call that progression-free survival. A year longer than the patients who didn't get the transplant. But so far, there's no difference in what we call overall survival, life and death. And that's because the patients who did not get the transplant in the first remission, when they relapsed, they went back into remission and got the transplant in second remission. So it suggests that, it doesn't suggest that that transplant versus no transplant. It suggests that doing transplant in first remission versus doing it in second remission have similar outcomes, though the people who don't do it early do have a more rapid progression. Next slide. So, and this just shows that even the patients who are MRD negative or MRD positive benefited by high-dose melphalan and a stem cell transplant, though the people who are MRD positive had a shorter progression-free survival than those who didn't. Next slide, please. So you could say that the standard of care is RVD, stem cell harvest, stem cell transplant, lenalidomide maintenance therapy. And I haven't gone into it, but there's very good evidence that people who take Revlimid, lenalidomide after an auto transplant have much longer progression-free survival and an overall survival benefit. Now, the big question is, instead of Velcade, which is, you could say, the first generation proteasome inhibitor, there's another one called carfilzomib or Kyprolis that that suggested that it might even be more potent than Velcade. And so that's been used as part of initial therapy for patients with myeloma. This study first looked at carfilzomib KRD, carfilzomib, Revlimid, and Decadron versus KCD, using Cytoxan instead of Revlimid. And it put to rest that it's very important to use Revlimid as part of the initial therapy. But more importantly, it asked the question of doing KRD versus KRD plus transplant. Next slide, please. And what it showed, just like the other study, that the patients who got KRD and a stem cell transplant had longer duration of remission than those who just got KRD. Next slide, please. Next slide. Next slide. And now, so VRD, KRD, both good initial therapies, but it seems that adding stem cell transplant still even further improves outcome. Now there's the newer medicine, daratumumab, that you'll hear a lot more from Luciano. But daratumumab, remember, is a monoclonal antibody that is targeted, that targets multiple myeloma, and has been a tremendous advance in the treatment of myeloma, particularly for relapsed disease. And because it's well tolerated and very active, we've been using it more and more investigationally as part of the initial therapy. And this is one of the first studies that compared a triplet of Velcade, in this case, thalidomide and Decadron, with or without the addition of daratumumab. So the patients were randomized to either VTD or Dara-VTD. They all got stem cell harvesting. They all went on to a stem cell transplant. They got some consolidation with VTD. And a very interesting secondary randomization was daratumumab by itself versus observation as maintenance therapy. Next slide, please. And what this study showed was the addition of daratumumab to the standard triplet significantly improved the response rate, and more importantly, improved the duration of remission, the progression-free survival, and also improved the minimal residual disease negative rate. Next slide, please. But I think probably more important part of this study is that it made us comfortable using daratumumab as a maintenance therapy. If you look at the patients who received daratumumab versus observation, daratumumab maintenance therapy was superior in terms of progression-free survival than observation. Next slide, please. And then, of course, there's currently studies going on looking at RVD with or without daratumumab. Next slide, please. And so far, the addition of daratumumab to RVD is causing much deeper remissions. Next slide. And next slide. And a hint that there is improved progression-free survival for the patients who are getting Dara VRD, though so far not a significant overall survival advantage for the patients who get this 4-drug regimen. Next slide, please. There is always more side effects when you start adding more drugs. In the case of Dara, it seems like it's primarily infection. Next slide, please. But what I wanted to leave you with is the summary of the initial therapy of the transplant eligible patients. It is remarkable that with the current regimens that we have, 80–90% of patients are having deep remissions, and that in the studies that look at how long people are staying in remission, most of the studies, the average duration of remission has not even been met after years worth of follow-up. So it is remarkable in my career for the last 30 years of how we've altered the outcome for these patients. Next slide, please. I do want to spend, if I may, two more minutes talking about the non-transplant eligible patients. This study, really key study, designed by Brian Dury, and is really one of the cornerstones of our therapy right now. It's the study that showed that RVD, or that made RVD the standard of care, RVD versus RD, for newly diagnosed patients with myeloma. Next slide, please. And you can see that the patients who got RVD, the triple therapy, had a much better progression-free survival than the patients who just got the doublet RD. Next slide, please. And overall survival was significantly better. Life and death was significantly better in the patients who got the triplet over the doublet. Next slide, please. There's more neuropathy associated with Velcade, as we keep saying. Next slide, please. And that's why most of us nowadays don't really use the regimen that is in all these studies. Most of us use what we call RVD light, which is a weekly dose of Velcade and frequently a lower dose of lenalidomide or Revlimid. And with that, look at the response rates are huge. 80–90% of patients respond with a very deep response with excellent responses. So that's frequently what we use. Next slide, please. The big question that was pseudo answered recently was, what is carfilzomib really better than Velcade? And this was a big study for newly diagnosed myeloma patients, VRD versus KRD. Next slide, please. Next slide. Yeah, and you can see there was no difference in either the duration of remission or overall survival in this group of patients. Next slide, please. And there was more side effects with carfilzomib, more heart side effects, lung side effects, kidney side effects, but more neuropathy with Velcade. And so I think the conclusion, next slide, of that study was that there is no significant difference between the two. Either one is reasonable, and you got to pick your poison in some ways. The final thing I think I want to show you is, of course, even in the non-transplant eligible patients, we're adding daratumumab as part of the initial therapy. And this is the key study that I think has changed our practice, the Maya study, which was a combination of daralendex versus lendex in the newly diagnosed patients. Next slide, please. And the patients who received the daratumumab had a much improved progression-free survival and a much deeper remission. Next slide. This shows progression-free survival and overall survival significantly better for the patients who received daratumumab. Next slide, please. But more side effects with the daratumumab, some more infections, some more GI side effects, et cetera. Next slide. And so in a similar vein, I think we've made tremendous advances over the last decade for the non-transplant eligible group of patients. Look, we've seen 80, 90% response rates, deep response rates, and long durations of progression-free survival. So it's been a wonderful time to be a physician dealing with multiple myeloma over this time. So thank you very much, and I'd be happy to join the conversation with my esteemed panelists.
Okay, what a great talk and a great set of slides there, Ed. Let's get everyone loaded up here. We've got Luciano there, and we got Daniel. Okay, we got some questions online here. The first one that I see is, I've reached CR but MRD positive. You want to take that for 20 points, Ed?
Well, what we know, in my mind, the way I see it is, what we know is that people who are MRD positive do seem to have shorter remissions than patients who are MRD negative. However, patients who are MRD positive can do very well for a long period of time. And as of this second, we do not know whether there's an intervention that we should do in patients who are MRD positive that is different than an intervention we should do for someone who's MRD negative. I'll tell you, one of the key investigators in the world who's trying to figure this all out is Luciano Costa. So we've got him right here. So he would be a perfect person to ask.
Go ahead, Luciano.
Well, a pleasure to join the panel, and thanks for this opportunity. And Ed, I couldn't start with a higher responsibility. No, I totally agree with your step. I think those are things we're trying to figure out. When this often comes up is after transplant, because that's kind of a traditional milestone that people take to assess disease. And there are clinical trials trying to answer this right now. So if you find yourself in this position that you're post-transplant with MRD positive disease, there are one particular trial that comes to mind is the Auriga trial that trying to test whether patients who are MRD positive benefit from double maintenance with daratumumab and lenalidomide. There's another study from the cooperative group with a similar design, regardless of MRD eligibility. So what we can do is encourage people to participate in those studies that will help answer those questions.
Yes. All right. I have one that came in from the email, and it's a COVID question, which I'm sure you all have been answering a lot of them. Here's one. What are the standard treatment protocols if a myeloma patient gets COVID-19, and if the immune system is already compromised, why should I take the vaccine if I might not be able to fight off the side effects of the vaccine? Anyone want to take that? Go ahead.
That probably Dan would be the one who's in the trenches thinking about that.
Go ahead, Daniel.
Absolutely, and I think it's a very good and valid question at this point. And I think there's 2 points to this question. If I understand it, it's understanding that if they had COVID, can they combat the side effects of the vaccine itself? And I think those are two different questions in reality. So yes, we know our patients are immunocompromised, and getting the actual COVID-19 virus does put them at a higher risk of having complications for that. We have not seen in Mount Sinai, we were an epicenter for the COVID evaluations, and patients did get the vaccines and did not have side effects. What we are seeing is that our patients may not have the most robust response if they're on current chemotherapies, immunotherapies, or even on certain types of research therapy at this point. But I have not seen any hindrance in them by getting the vaccine itself or developing unacceptable toxicities or adverse events by receiving just the vaccine. It's really important. I think, I think Ed and Costa will agree with me that really the protection of having the vaccine up front is highly recommended versus not getting it and getting the disease itself. But do you guys agree?
Let me, obviously Colin Powell's plight brought a lot of this to light, so yes, I think that it is true that patients with myeloma probably are less likely than the general population to respond to the COVID vaccine. However, in our experience, and I think in general experience, it is where 95% of the general population respond to the vaccine. I think it is something like 70% of the myeloma patients responded. So you should go into this as a myeloma patient, assuming that you will respond to the vaccine, and the vaccine will help. And it's the best way we know of to try to prevent. It's not absolute. There are still people who can get COVID who have a normal immune system, who are and if anything, it should motivate everyone around you to get vaccinated, to try to limit the exposure to the infection.
Of course, I agree with Daniel and Ed said, but I think there was a very important misconception that was embedded in the question, that because patients have a quote unquote reduced immune system, you are at higher risk of having complications from the vaccine. And that is absolutely not true, okay? Serious infections from vaccine are extremely rare. Those are like anaphylaxis, which are like extremely rare, like less than a handful in a million people vaccinated. And there's no rationale or data to tell us that patients with myeloma are at increased risk. So, there's absolutely no problem in getting the vaccine. I think we tend to think of, I think we got spoiled by, the efficacy of vaccines in other diseases, where we see, diseases being vanished from the face of Earth because of immunization, and somehow a less than 100% efficacy seems like a discouragement for some. But cancer patients deal with this all the time. If you think about, think about myeloma, it's a disease that has a natural history that kills people, and all we do is put medications that reduce risk over time. None of our therapies cure everybody. So our interventions we make, either vaccine therapies, are about risk reduction. And the risk reduction might not be the same if you have myeloma than if you don't, but it's some, and it's meaningful, and it's safe. So I'm a little bit on the extreme end that I discourage and I don't bother checking titers, because at the end of the day, there's only one decision to be made, which is to take the vaccine. And when the decision has no downside other than an inconvenience, then you don't dance around, you just take it. And that's what I tell every single one of my patients. And now that we have data for second dose and boost, that makes that case even stronger.
I agree, Dr. Costa, and no test is also perfect either. So even if our patients measure a very low or nothing, it doesn't mean they still don't have a response. The test just might not be able to measure it. So even having a minor, I call it the dust covering of some type of antibody that the COVID vaccine has made in your body is still a protective mechanism going forward and protecting you and your family and your loved ones around you. So I think it's a great, and I agree, everybody should just line up and get the vaccine.
Yes, thank you for sharing that. Ed, we got a question from Jack, who runs the San Francisco support group. Great slides and talks. Can you clarify high risk factors? You see that question?
Yeah, you mean clarify high risk factors.
That's what I meant. Sorry.
Yeah, I'm just trying to figure out what's the focus of the question. In my opinion, the issue of high risk myeloma is important to some extent, because the old treatments that we had were really very ineffective in that group of patients who had such rapidly dividing resistance mechanisms to their cells. So, certainly alkylating agents don't work as well, et cetera. But remember that I still remember when I had a referral from Bartologhi of a patient who he just, by all the predictions, was not going to be with us for long at all. And that was about 10 years ago, and the guy's doing just beautifully with his high risk disease. So I think that there are many aspects that predict a more resistant disease. I'll tell you, one of the things that I didn't speak about that is becoming more and more evident is extramedullary disease that is outside of the bone marrow, that when tumors of myeloma start going into the skin or into other areas, that disease is really probably the most challenging right now. The factors that we traditionally talk about at the initial diagnosis are those chromosomal abnormalities. And I think we all feel that the 17p deletion is difficult. And but the more of these factors you have, the greatest. But I would say that it's not just one important, it's more of the constellation of these factors that really helps guide us in the treatment for the patient.
Constellation of factors. That's fantastic. Never heard it put that way before. Well, I know we have more questions, and we'll try to get them in the next round, but I'm trying to stay on time. So we're going to take a little break, right, gentlemen, and thank you so much so far. We're going to take a break for a few minutes here. I'd like you to stretch and listen to our mindful meditation, and then we'll get back to this. Thanks, everyone. Well, here we are back again. Welcome. I was talking to some of my colleagues about what Ed said about the constellation of factors, and I bit my tongue. How many people bite their tongue? Doesn't it feel just in the perfect place? So I will never, ever forget the constellation of factors. Thank you, Ed. Not for the tongue biting part, but for the great wording there. All right, now we had a lot of questions at the last break, so I'm going to try my best to get the right time, but we probably will go a little like towards 12:30 when we finish. God, very spirited questions. I'm incredibly grateful. Now, the next one, relapse therapy and clinical trials. Now, listen, this is a great talk to talk about where you are right now and what is happening and what possibly could happen, plus what's going on with clinical trials and how they apply to you and how to get in or not get in or whatever the questions are right there. And this is done by a good friend here, Luciano Costa. He's at the University of Alabama in Birmingham, and I've worked with him 3 times now, and we were doing live ones before, but that was in 200 BC, whatever it was, so long ago. So Luciano, will you take over with your 2 great talks for us?
Thanks, Kelly. Always a pleasure joining you on the stage, even if virtual, and now it's a pleasure interact with our dear patients. I'm going to talk a little bit about relapsed myeloma in clinical trials next. Do I have control? You can, okay, there you go. So I think that, of course, we're talking after all you heard from Dr. Ed. You know, patients tend to either receive a therapy and then be observed, or receive a therapy and stay on maintenance therapy. And a good question is when to change the therapy, or when to restart therapy if the disease has been held, if treatment has been held. And clearly you do if the patient develop new signs and symptoms of the disease, like say patient develop a new bone lesion, or now the anemia is worse, and that's clearly related to the myeloma, not to any other reason. We often do because before those bad things happens, just because you're seeing an increase in the paraprotein, either in the blood or in the urine, which is a clear, consistent indication that the therapy is no longer working. Sometimes we change therapy, not because it stopped working, but because the toxicities are just not tolerable. We cannot make adjustments. In any case, your goal should be to accomplish all those four things, which is to regain control of the myeloma and keep so for the longest possible time, alleviate the symptoms the patient's having, prevent those events. You know, you certainly want to make your changes before the patient has a new fracture, because as you know, that can be debilitating and painful, and ultimately, you know, improve survival. Next. So how do we choose such regimen? The most important thing is there's not a one size fits all. You know, we myeloma doctors spend an incredible amount of time debating one another of what regimen is better. And of course, there are regimens with greater or lesser efficacy. There's no such a thing as a universal answer for what's the best regimen for patients in first relapse, for example, because it depends on a lot of things. It depends on the disease characteristics, you know, how long the disease was under control, what was the patient taking when the myeloma got worse? What are the toxicities that the patient has? Those patients still have significant neuropathy that will preclude some medications. How are the blood counts doing? Will this patient tolerate this drug that can lower the blood counts? The convenience for the patient, that's particularly important in people who are either debilitated or people who are busy working, frail, and so forth. In any case, the pillars of therapy remains the immunomodulatory agents, the proteasome inhibitors, and now more so the monoclonal antibodies. And a message is to always consider clinical trial. I mean, every time you come on a therapeutic decision, either to start or not start treatment, change or not change the treatment, the myeloma is progressing, what do I do next? Those are the time to pause and see if there's a clinical trial available and how that could fit you and if that would be beneficial for you to participate. Next. This is what we have in our toolbox. It's probably already outdated summary of all the drugs that we have available. Some of those have formal FDA approval, some don't, but they have been grandfathered in, so to speak. You know, we use melphalan mostly in high doses as part of the transplant, as Ed explained. Cyclophosphamide doesn't get a lot of love, but is a helpful agent that we often use to combine with other more fancy agents. Bendamustine is also often employed, usually in later lines of therapy. We have the immunomodulatory agents, the lenalidomide, and pomalidomide, the proteasome inhibitors, bortezomib or Velcade, ixazomib or Ninlaro, carfilzomib or Carprolis. More recently, in the last 5 or 6 years, the monoclonal antibodies, elotuzumab, daratumumab, and isatuximab. And there are others, corticosteroids that have been part of just about every single regimen, Doxil, that is more of a traditional chemotherapy, panobinostat, and more recent selinexor. I'm going to tell you a little bit more about those drugs. And then we have the things that are more exciting, the new immunotherapies. I'm going to talk to you about the belantamab and about ide-cel. And there's another very, very long list of things, particularly in this last category, that are in development, and I think you're going to be very quick to reach the clinic. Next. So let's talk about the monoclonal antibodies. I think they have made the greatest impact in recent years. I'll now explain them what they are next. And I'm going to start by explaining elotuzumab, which was really the first monoclonal antibody approved to treat myeloma. I find this kind of the ultimate irony, because as Ed explained to you, the feature that is unique to myeloma is a cancer that produces antibodies. And while antibodies have been used to treat other cancers for, almost 20 years now, it has only been recently that we had a monoclonal antibodies to treat myeloma. And the elotuzumab, the way it works, it has the capacity to bind to a protein that is present on every plasma cell called LAMF7. And by binding to it, it facilitates the engagement of a physiologic normal mechanisms on our immune system to eventually destroy the myeloma cell. Next. And why was that important? That has been tested in now 2 large trials. One is called Eloquent trial that took patients who have relapsed myeloma, and they got treated with Revlimid and dexamethasone, or Revlimid, dexamethasone, and daratumumab. And elotuzumab. And you already saw through Ed's presentation, and you're going to see a lot of this today, those curves. Those are, we use that all the time. This one is for progression-free survival. And the way you read those curves is, for each one of those lines is one group of treatment. And this you have time, and this you have the proportion of patients who have not died or had a progression of disease. So for example, here, at 12-month, 57% of the patients with RevDex have not died or have progression versus 68% who took elotuzumab. So the higher the curve on top is always the winner. So in this case here, you can see that patients who took elotuzumab had a better progression-free survival. Next. And there has also been the other monoclonal antibody that I think it got a lot. It was not the first, but was the fastest in development, was the daratumumab that binds to a different protein called CD38 that is also present on every single plasma cell, including the myeloma cells. And also work through engagement of several, I'm not going to bother you with the details, but several different ways our immune system has to kill other cells. Next. And we've seen that trials. Here you have daratumumab added to Revlimid and dexamethasone. So the greater the distance between the curves, the higher the magnitude of the impact of that therapy. So a big difference whether you get Revlimid, dexamethasone alone or with daratumumab, higher proportion of patients with response and longer lasting response. Next. The same has been shown in combination with bortezomib. So here Velcade, dexamethasone alone versus Velcade, dexamethasone and daratumumab. Next. Now, what about proteasome inhibitors? So as Velcade, as you heard, is kind of the founder of that class, was the first proteasome inhibitor. It was really a revolution in myeloma management 15 years ago, but has been some newer ones, if we can see the next slide. And one of those is carfilzomib or Carprolis. that has been tested again in patients with relapsed myeloma, receiving either Revlimid, dexamethasone alone, or Revlimid, dexamethasone with carfilzomib, and again, you have an improvement in outcomes. Next. This is a very important trial. Ed showed you that Velcade versus carfilzomib in newly diagnosed patients, there's no difference, at least when combined with Revlimid and dexamethasone. But in the relapse setting, it's a different story. So this is Kyprolis dex versus Velcade dex, showing an improvement for the group of patients who get Kyprolis. Next. And last but not least, ixazomib is the only one of those that is available orally. So oftentimes people choose this drug because of that particular feature. And here's the same thing, Rev-dex plus placebo versus Rev-dex plus ixazomib, and the group that got ixazomib have better progression-free survival. Next. So those are the main trials, but as you can see, there's a bunch of trials, 8 I counted, that shows that something added to Revlimid and dexamethasone is better than Revlimid, dexamethasone alone, and something added to Velcade, dexamethasone is better than Velcade, dexamethasone alone, or that carfilzomib is better than Velcade in those patients with relapsed disease. So I think the message here is, in general, 3 drugs are better than 2, and Revlimid dex or Velcade dex are usually inferior regimens. We tend not to use those unless there are some peculiar features about that patient that precludes the use of 3 drugs. Next. Next, the challenge we have, however, is nowadays that we use Velcade, Revlimid for almost everybody up front, and people tend to stay on Revlimid until progression. Most of this data do not apply to those patients because, for the most part, they did not include patients whose disease was getting worse on Revlimid. So for those are patients for whom we don't consider Revlimid to be a good option on the next line. So we have studies that help us take care of those patients. For example, Eloquent 3, very similar to what you saw before with the elotuzumab and Revlimid, but here with pomalidomide, which is a 3rd generation immunomodulatory agent. And again, you see the advantage of combination of the 3 drugs versus 2, even though the vast majority of the patients were refractory to has disease refractory to lenalidomide. Next. More recently, we have demonstration that daratumumab combined with pomalidomide and dexamethasone also improves outcomes, the so-called Apollo trial. Next. And the same is true for ixazomib, which is another CD38 monoclonal antibody, very similar to daratumumab in target and mechanism of action, but different in route of delivery and frequency of dosing. But the results are nearly identical with almost the same magnitude of improvement in progression-free survival. Next. Now, we talk about the carfilzomib, how that improves outcomes compared to Velcade in relapsed disease. And we talk about how impactful daratumumab was. So what about if we combine those 2 great drugs? And this was done on the Candor trial. Patients who with relapsed disease receive either carfilzomib and dexamethasone versus daratumumab, carfilzomib, and dexamethasone, a very powerful regimen. And you see that, again, the group that received 3 drugs did far better. With really the majority of patients not having relapse, not having need to get any additional therapy, despite more than 2 years on treatment, which is really impressive for patients with relapse disease. Next. Patients not only had longer responses, but I also had deeper response. That's actually why they probably had longer responses. And the response tend to be quite fast, with most patients responding at 1 month. Next. Very similar trial, the IKEMA trial now with isatuximab, is a KD far better than KD. Next, also showing greater levels of response and more patients achieving an MRD negative response. Next. So, sorry for the wrong title here. I really want to go into other types of therapy. They're not the proteasome inhibitors, the immunomodulatory agents, and the monoclonal antibodies, including some of the things that have really excited the field and generated a lot of interest. Next. So I'll talk first about venetoclax. This is a drug that you might hear about. It's not a drug yet approved for multiple myeloma. And that's perhaps one of the first few examples where knowing the peculiarities of one's myeloma might make a difference, particularly chromosome changes. For the most part, we have used chromosome changes to say, well, those patients have standard risk, those patients have high-risk disease, but as Dr. Ed pointed out, we really don't know how to use that to change therapy. And this might change with venetoclax because there's about 1 in every 5 myelomas carry a genetic change called translocation 1114. And we have known for quite some time that those cells look different. They have some different markers. They clinically may behave slightly different. But this you have an example where a drug that is now approved to treat some types of leukemia, when used in myeloma that has the translocation 1114, the chances of response are very good, about 40%. But if you don't have the translocation 1114, the chance of response is almost 0. And this has been seen in other subsequent trials, including in some that Dr. Ed had a huge contribution on. So this is becoming perhaps the first example in myeloma where we're going to have a therapy that is specific for a subset of patients based on a chromosome abnormality. Next. The other drug is selinexor. That's the first one with a unique mechanism of action. This drug is used, it blocks this protein called XPO1 that is inside the cell that is essentially its function is to pump out of the cell some pieces that's supposed to be in the nucleus of the cell. And that's a trick that the cancer cell uses to become resistant to some of our treatments, including corticosteroids. So when you block this XP11, the cell might not survive and the cell might become more amenable to treatment with corticosteroid, with dexamethasone. This drug is approved, it's an oral drug. Had some hindrances at the beginning because the dose approved was just too high, causing a lot of side effects with nausea, weight loss, some changes in blood chemistry and so forth. We have gotten a little bit better by using lower doses and less frequent dose. It can be helpful in about a third of the patients when the disease becomes refractory to other agents. Next. Now, where the excitement is with new immunotherapies. We talk about monoclonal antibodies. They were revolutionary, but they were just the beginning. Next. So this is a very rudimentary display of different types of proteins that we can find in the surface of plasma cells. And each one of those long names that you see is one therapy that has been used or is being developed that targets that particular protein. And that's kind of very important because as we come up with newer targets, that comes up with new therapies and the possibility of patients enjoying disease response for a very long period of time when you target different targets at the same time or sequentially, as is becoming more and more of the norm. Next. So one first example of that, it's a drug that is now approved, can be used. It's called belantamab mafodotin. I explained to you how monoclonal, the antibodies like elotuzumab or daratumumab just sits on the antigen on the surface of the cancer cell and just brings in, just engage the natural immunity of the patient to destroy the cancer cell. Well, the belantamab does that too, but it also comes with a payload. It comes bound to a drug that it's a drug that is very powerful at killing the cancer cell, but cannot be given intravenously because it has too many side effects in other organs. So by binding that to an antibody, you kind of have a target delivered, and you achieve high levels of the drug inside the cancer cell and not elsewhere. And that has led to frequent responses, about 30 to 35% on patients who had heavily pretreated multiple myeloma. And the patients tend to stay without disease progression anywhere from 3 to 5 months. That is good, but it's not great. So there are different ways that we're attempting to improve the efficacy of this drug, including combining with other myeloma agents. It has a very unique toxicity that is keratopathy, or irritation of the cornea. So it requires an ophthalmology visit for every dose that is given, and this drug is given currently every 3 weeks. But the other thing that is exciting about this drug, it was the first drug that has this target called BCMA. And you're gonna hear this target kind of over and over and over because it has been explored with other, perhaps more promising approaches. Next. So let's talk about CAR T cell. I think it's probably the top buzzword in myeloma currently, and I think for a good reason. So CAR T cell, it's really a type of therapy that stands for chimeric antigen receptor T cell. That was really started at Ed's institution, more than a decade ago, and has reached the clinic, has become commercially available products as of for the last 4 years, initially in leukemia, lymphoma, and since the beginning of this year in multiple myeloma. And I often explain to patients using the kind of the transplant paradigm, although this has nothing to do with transplant, the mechanics is somewhat resembling. So I use that just as a reference. So when like transplant patients undergo an apheresis, but here is not to collect stem cells. So there's no need for mobilization. There's no need to give medications that make the stem cells go from the bones into the bloodstream, because we're collecting cells, collecting lymphocytes that are already in the bloodstream. And so usually we get all the cells in one session. And those cells are sent to an outside laboratory. In most cases, we talk about commercial CAR T cell. And there's a little bit of a black box there, which is called manufacturing. But what happened there is those cells are purified, they're expanded in culture, so they make more lymphocytes out of those lymphocytes that you send. They are purified to select the T cells. And then usually with the assistance of a virus, because viruses are excellent in invading cells and carrying genetic material into the cells, because that's their mechanism to survive. So we use a pig bag on a virus to transfect a gene that teaches that T cell to, instead of doing whatever you were doing before, now you're going to express this receptor that is capable of binding to something that is on the cancer cell. And in the case of myeloma, that something happens to be the BCMA that I show you. So when the cells are ready, then we proceed with the patient's treatment. And for that, we use some chemotherapy that we call lymphodepletion. So that chemotherapy is usually with drugs that have no or little effect on the myeloma. They're not there to kill the myeloma. They are there to shut down the other lymphocytes that the person has in the body. And that creates an environment, an immune environment that is receptive, that helps the CAR T cells that are going to be given to thrive. So this chemotherapy barely does not cause hair loss, barely cause nausea, can cause some very transient suppression of the blood counts. That is nothing comparable to what people have with transplant. And the T cells are then infused as a single, very rapid infusion. And those T cells, they get in the patient, they find the cancer, bind to the cancer, engage and kill the cancer cells, but they also expand more in the person that over the next several weeks. So it becomes kind of a chain reaction that it kills, multiple, and in some cases, we hope all the cancer cells in a matter of a few days. Can you show the next one? So that has, and here's is a little bit of a diagram on how the gene that the virus carry into the cell teach the cell to make this receptor that identifies the tumor cell. If you show the next one. So the one CAR T cell that is approved is called IDA cell. The commercial name is Abecma. Next. And this came from the KARMA study. And you see here the process that I described. And of the 140 patients collect cells, 128 got treated, which illustrates one of the problems that sometimes during those 4 or 5 weeks that it takes for the cells to be manufactured, the patients sometimes don't do well because their myeloma is progressing rapidly. So in some cases, we use bridging chemotherapy just to cool down the disease while you wait. But unfortunately, those patients sometimes have disease that's so advanced, they cannot resist the wait. That's why the number of 128 does not match the number of 140 that had apheresis. Next. But when you treat the patients, those are the most common side effects. The one that is a signature of this therapy is something they call cytokine release syndrome. And the way I explain to patients is, imagine you got the flu. And when you have the flu, you have your body aches, you have a fever, you have kind of muscle pain, you don't want to do anything, at least I don't when I get the flu. And that is not direct effect of the virus. That is an effect of your immune system reacting to that infection in a physiological, in a natural way. Imagine now that we took control of that process and we put that on a fast pace. We have an exacerbated broad activation of the immune system. And that can lead to fever, body pain, feel like you have the flu, which is very common. You see that in over 90% of the patients in some studies. But that reaction can become very exacerbated and have changes in blood pressure, change in breathing, changes in renal function, and organ function can even become fatal. We call that cytokine release syndrome. Most patients will have, few patients will have the serious types. It's difficult to predict who's going to have the very serious type, but we now have ways to mitigate that, to improve that, and to deal with that a lot better than we did perhaps 4 or 5 years ago. Much more common is lowering of the blood counts. Infections are relatively common. And the other toxicity that's pretty scary is the neurotoxicity. And that was quite a thing on early trials of CAR T cell, mostly in leukemia, lymphoma. Fortunately, in myeloma, has been less common. And that can manifest in itself as somnolence. Sometimes people kind of lose their words, sometimes for hours or for days. They're there staring at you, but they can't come up with words, can cause seizures, and in extreme cases can cause death. But that, you got to keep in mind, is very uncommon. With this particular treatment that is now approved, is less than 3% of the patients. And again, we now have far better ways to manage that complication than we did just a few years ago. Next. Why we pursue this complicated therapies? Because it works. This one that is approved, ide-cel, the chances of response with a higher dose, which is the dose that we use, is 82%. And patients tend to have disease control for about 12 months when they receive the higher dose. So that is far better than anything that has ever been used in this setting of patients with 4 or more prior therapies and refractory to all the mainstream classes of myeloma treatment. Next. There are other CAR T cells in development. The one that is likely to be the next one to hit the market is cilta-cel, and that has been explored in this CARTITUDE-1 trial. Next. Again, next. Very high chances of response, 98%, including a large proportion of patients achieving complete response. Next. But some of those responses tend to be durable, with 2/3 of the patients is still with disease control after a year and a half. Next. But again, the main toxicities being the cytokine release syndrome in 95% of the patients, and neurotoxicity of some extent in about 20% of the patients. Next. Now, what if we try to engage those T cells to kill the cancer, but we don't have the time or don't want to go through the whole trouble of collecting cells, manufacturing, infusing back? So the approach to do that is what's called bispecific antibodies. Those are antibodies that have, think of them as having 2 arms, one that grabs the cancer cell that has specificity for the cancer cell, and one that grabs the T cells, which are the killers of our immune system. And by putting those 2 together, by making a bridge between the 2 of them, you're achieving activation of the T cells and cause the T cells to directly kill the cancer. And that's an antibody, something that can be stocked, that can be on the shelf, and you can start treatment right away without having to wait the 4 to 6 weeks for CAR T cell manufacturing. Next. There are several CAR T cells, bispecifics being developed, targeting BCMA, like the CAR T cells. The one that's perhaps further along is the teclistamab, that is administered subcutaneously. Next. And that has also can cause cytokine release syndrome, perhaps less frequently, 60–70%. Neurotoxicity is far less common. And the chances of response are also very high. 2/3 of the patients having a response. Next. Of course, none of the T cell engagers are approved yet to be used, although we anticipate it won't be long before one or more of those get FDA approval. Now, all those therapies, the ones that are being developed and the ones that are available to us and to our patients, they only became possible because of clinical trials. There's absolutely no other way to get cancer treatment, a human cancer treatment developed without clinical trials. So that takes participation, that takes engagement from patients and myeloma doctors. So clinical trials are a really important option for everyone. There are clinical trials for every question in myeloma in every setting. So they're important for people who have been newly diagnosed, patients who may even be questioning whether or not they should be on therapy, as well as for patients who have advanced disease. They are not for the young and fit. They are for people of all age, all backgrounds, and I think we suffer from a big problem, which is our clinical trials tend to include too many patients who are white and young and overly healthy, while our real world myeloma patients can be quite different. They take into account all those factors as well as disease stage, other treatments, and other comorbidities. So always important to bring up with your physician, with your healthcare professional, with your nurse, whether or not a clinical trial is available to you, particularly when time comes to make a treatment decision. Next. So how do clinical trials work? You hear about phase 1, phase 2, phase 3, phase 4, and they are all important and they all serve a purpose. Phase 1 is essentially you have a drug that is on the beginning of its development, and you don't even know if it's going to be tolerated in people, if it's going to have some toxicity that would preclude it from being developed further. So essentially you're testing in a few patients to just see if it's safe and see if you can optimize the dose. Of course, you can only do that in patients who oftentimes don't have other options, because you have a drug that you don't even know if it's safe, you know if it's going to work. Nowadays, things get a little bit murky, and oftentimes we see a strong efficacy on phase 1, and then we try to expand and get some information on activity. So now you see sometimes phase 1 trials with more than 100 patients. Phase 2 is now you have a dose, you know it's safe, you really need to refine the understanding of how well it works. So now you take a more homogeneous patient population. Usually have about 100 patients, can be higher. And your primary objective is to learn the efficacy of that drug or that treatment on that particular group of patients. If that looks good and looks promising, you go to a phase 3 trials, and those are the ones who change our practice in a more definitive way. Let's say I have treatment A, that's the standard way I treat this group of patients, but now I have this treatment B that is looking safe and looks super active on a phase 2 trial. So let me confront the two. Let me see if the treatment B is really going to be looking better, it's going to perform better than treatment A, and can replace treatment A as a standard of care in this setting. So those trials are always comparative. They always have 2 or more arms. They accrue hundreds, sometimes thousands of patients. They take years to mature, but they give us answers that are definitive, and oftentimes they substantiate the approval of new treatments. And phase 4 is once you have a treatment already established and commercialized, and you're essentially getting additional data or on a patient population subset, or essentially by pooling a very large number of data for looking for a very uncommon toxicity signal, for example. Next. So there's a lot of misconceptions and concerns when we talk about clinical trial. And one of them is about placebo. What about if I have this serious cancer and I go on a clinical trial and I get placebo, which is a pill or IV that mimics in appearance the treatment, but has no active principle. Well, placebos are rarely used in cancer clinical trials. And the only time they are used is when the question is, does this new drug add to this established standard treatment? Then you're taking that established standard treatment plus the drug or the placebo. So in no circumstances, the established standard treatment is withheld for a patient for the sake of testing a new drug and a new treatment. Okay, and that's a very important concept. Next. So why do so few patients participating in clinical trials? It's really a national tragedy that less than 10% of cancer patients participate in clinical trials in this country, even though we are often the first ones to approve a new treatment. And the reason may be many. One is not being aware of clinical trials, not having access, so they're being treated on a facility or in a cancer clinic that does not have that particular trial for that patient. There are issues with fear, distrust, and suspicious of research in general. Some practical obstacle, oftentimes we have, being on a clinical trial requires some extra visits to the clinic, some extra assessment, and people have difficulty with that because they have to work or have some other obligations. Insurance or cost problems. Important to remind everybody that in every institution, when you're going to activate a clinical trial, there's a careful discernment of what costs would incur anyways, just for being treatment, and were charged to you or to your insurance, and what costs are related to exclusively to the clinical trial participation. There's a cost covered by the sponsor of the trial frequently. And there is federal law embedded into the Affordable Care Act that protects the payment by your insurance of the usual cost of care for your cancer, including participation in clinical trial. And on the other side, sometimes people can feel coerced to participate because they don't want to go against the physician's wishes or advice, with something that you should all feel empowered to ask questions and to disagree and to not accept the recommendation if after you collect all the data and you think that's the best decision for you. Next. So some common misconceptions. One that is the clinical trials is what we look for when we have no other options. And that's absolutely not the case. Yes, when all the existing options have been exhausted, that's oftentimes when we look for those phase 1 trials or things that we don't know if it's going to work yet. We're looking for safety signal first. But clinical trials are for everybody, including patients with newly diagnosed, because we need improvement in all settings, and new therapies are being developed in all settings. You don't know what you are getting, and that is almost never the case. The only exceptions are those trials that have a placebo component, but they are very, very, very rare in cancer in general, certainly in multiple myeloma. So you know what you're getting. There are too dangerous and too many side effects. And that's absolutely not true. When you participate on a clinical trial, you're given an informed consent that lists every single known or possible side effect upon that treatment. And if you're talking about a phase 1 clinical trial with a first-in-human drug that you're signing up for because you have no other option, you might, yes, have side effects that have not yet been described. But in any other setting, you know, it's unlikely that you're going to come up with something that hasn't been described when the drug is already on a phase 2 or a phase 3 trial. If you receive a treatment off trial, we don't have to give you a 40-page informed consent. So sometimes we tell you the top 3, and people walk away with a sense of a false sense of security just because we didn't list all the 50 things that have been reported. So that the regulatory obligation to be comprehensive in our description of side effects when you go into clinical trials sometimes give people the wrong idea that is more toxic and have more side effect. The sponsor investigators will hide information from you, and that's absolutely not true. Everything has to be disclosed on informed consent, everything that is known. And if you are in a trial that is comparative, for example, of treatment A versus treatment B, and there are interim analysis, there's an external board of experts that look at the data. And if at any time it's found that one group is more toxic or inferior to the other, that information has to be disclosed. And something one does to help others. While that is true, the primary objective is to help yourself. Next. And last but not least, I want to remind that information is key and it's free. There is this federal maintained website, clinicaltrials.gov. Every single trial done in the United States for any condition is available on this trial. It's an easy place you can go and find clinical trials that might be appropriate for you. Next. Thank you so much. And I look forward to engage in the discussion after the next presentation.
That's fantastic. What a great presentation about what's going on out there. Thank you so much. Well, Daniel, as our Nurse Leadership Board member, has been biting his teeth, ready to go. He's all excited. Daniel, I don't want to waste any time. Take it over.
Thank you, everyone. Thank you, Kelly. And I am so honored to be on this panel with Dr. Stadtmauer and Dr. Costa. I think really kind of let's talk about, as what I think our theme of the day has been, is really our journey, our galactic journey, if you think about it, in patient care and caregiver care from the time of diagnosis and time of relapse. Next slide, please. So like Dr. Stadtmauer said earlier on, you know, it's really all crew members that really are successful in making a successful journey together, right? We all want to take a trip. We want to make sure we have all our stuff on board. So really having, you know, you and your caregiver is part of a bigger team, having your myeloma specialist, having a general hem-onc specialist for you, and all of your others, your primary care doctor, subspecialties, palliative, or really supportive care, right? For pain management, which we'll talk about a little bit later, nutritional supports, all these special teams, social work, that really will help us stay together on our journey. Next slide. And I think really what has been explained quite well during this discussion today is really exploring the options and planning your course. I think looking at all the new therapies that are available, as we said earlier with Dr. Stadtmauer and Dr. Costa just really addressed in his for relapse patients, and looking at the proteasome inhibitors that are available, immunomodulators. And what this slide really demonstrates is, look at all the new combinations that we're seeing involving the monoclonal antibodies with immunotherapies and some dexamethasone, looking at the new nuclear export inhibitors in their combination. A lot of these medications first came out as single agents, and that we have seen over time, and with all the research going on, the efficacy is that when we combine them with other modalities or other mechanism actions of different drugs, we get a better progression-free survival or better efficacy. And especially like Dr. Costa talked about just recently, the role of CAR T cell and the role of research in moving forward. Next slide, please. So I think one of the most important things to discuss, and when you are part of that team and when you come into a cancer center or your private care doctor hematologist, is really being empowered and talking about what are your needs. And I like to say, we always used to say the television show Fathers Knows Best or the doctor knows best. And I think really now we're in an age of it is a shared decision time. So it's important for both sides, your caregiver and you as a patient, to be very involved in your care, participate in decision making. You want to ask questions, whether you think that, I have to say, every question is important. There's no such thing as a bad question because it is new to you. Then it's a new and important question for you. So looking at that, asking time to consider options, telling your physician and your care team, saying, I need a little more time because I have many questions. Can we talk about it? Looking at understanding options, use reliable sources. And we've talked here, the International Myeloma Foundation has an enormous library of information to support the patients and their caregivers with information on drugs and options that are available. Reach out to them and do that. Use also being part of these support groups, talking to other patients and their caregivers and see what they've been involved in and what they're on and how their care teams are managing, which we'll talk about later, some of their side effects. And be honest and open dialogue. I will say from a personal experience, I want to hear from my patient. They generally don't want to hear from me all the time. I truly feel that way at times. But in reality, I want to hear what they're thinking and what the caregiver is thinking. If there's their wife, their spouse, their partner, their family members, who is ever in the room, I want to know what's going on with them and see how I can help them in their journey, in their myeloma treatment journey. And arrive at treatment time decisions together. We're going to talk about that, and we've seen that through this entire program today, all the options that are available, but really what options work best for you. Next slide, please. So how should we, Major Tom to ground control? I have to be honest with you. I just learned that's actually part of a song. So those who know it, I did not know, but I think it's offering a great communication effective with your healthcare team or your crew. So write down questions. I think being prepared coming into as your first visit, each visit, at the time that you think you're relapsing, you want to write down the questions, concerns. Be ready for it. So if you're at home, you have a thought, use it in your phone, write it on a piece of paper, put it in your wallet. And when you come to your meeting with your physicians and your care teams, really bring that and ask each one of those questions. Again, don't hold back. Let us know. Bring all your current meds and supplements. And I think that's very important. We are part of your care team. We're your hematologist and we're taking care of you from an oncological perspective. But really, most patients have other specialists, right? Nephrologists, cardiologists, rheumatologists. And it's important that we all communicate together. So bring all your medications and then supplements that we take on the side. If it's, a B supplement or a vitamin or things that you think you would like to try, and then discuss it with your team. Okay, any medical or life-changing since the last time your visit. So if you notice you didn't feel well, you had fevers, you were hospitalized, and you weren't able to communicate with your team, let us know. And any new symptoms. I think symptoms are important to discuss, whether you feel they're very minor and don't want to tell your team, or they're major and you're still hiding from your team. Important things to understand is that symptoms may not always be related to your disease. It also could be related to the treatment or the medications that we're giving you. All medications have side effects. So allowing us to know how you're feeling may be able for us to either adjust the dosage or add certain medications to help decrease those side effects that you have. And I always say, speak up, be loud, be heard. I think that's really important. Ask the most important questions first. Don't think everything is small. Understand your treatment plan and the next steps. I think being very clear and saying, where am I going? What happens if this doesn't work, or if I start to relapse on this current therapy? What are you thinking? I read this on the IMF website. I want to talk about this with you. Okay. And have a list. And I think this is important. Have a list of who to contact and when, who to know who your key players are in your team and to call. Because I know sometimes it's difficult. You meet many different social workers and other people, but who should be the point person if you don't feel well or you have questions? And I have to be honest, I always need a second person in a room when I'm with somebody or hearing a lecture or at a medical doctor's appointment. It's always good to have another set of eyes or another set of ears to hear what's going on in the discussion, because we don't all, I don't always remember things when I'm hearing it. I don't always, I walk out the door and then my nurse would say, did the person remind you of this? And I say, oh, they might have mentioned it. Thank you for reminding me. Again, having another person in the room, a caregiver, a friend, somebody there to support you is a great support. They can write down the questions that you asked and the answers just in case you did not have that time. I think navigating at home, communicate with other members in your healthcare crew, like your pharmacist, whether it's your local pharmacist or your pharmacist at your institution. I know in my institution, our pharmacist meets with our patients while they're having their treatment and infusion, but there's also an open line communication if they have any questions about new medications or therapies that they're being on. So knowing other people is very helpful. And it's important to take medications on schedule or the way they're prescribed. And I know that can be challenging at times. A lot of us are on multiple meds. It's tough to take everything at 10 a.m. in the morning, or can I, so discussing it with your care team, is there a way to spread out some of these medications to keep them on the correct schedule? Don't modify it. My biggest opinion is if you can't take your medication for some reason, you don't feel well, you're nauseous, then you call your physician and you discuss that with them. Just withholding the drug or changing it may also change how it's effective in your treatment. And again, always follow up. I will say, we're here for you, an open phone call. Some, healthcare systems have an electronic email system so that you can communicate through the electronic health record systems. Any way that you can reach your physicians safely. And I will say this, if it's an emergency, emails don't always get picked up as quickly. So really either a phone call, and if it's a true emergent, I will always say you call 911 first, then you call me and let me know what's going on. Next slide, please. Again, like I said, really take the time to consider other options. Go to our website. Whenever you have treatments or stop working, have these options and discuss that. Next slide. Really talking about and kind of, let's end this, I would not say on a high note, but I really want to say really trying to help support you through your treatment. So we know that the longer you stay on therapy without really any symptoms, the better progression-free survival you'll have. So, let's talk about symptoms and what makes you feel good and what makes you feel. But we know that myeloma, like Dr. Stadtmauer said earlier, there are symptoms of the disease itself. So high calcium elevation, renal dysfunction, low red blood cells, anemia, and bone pain, right? Those are very common. We call them the crab symptoms, very common symptoms of presentation, but even at relapse, like Dr. Costa said. But also fatigue. Fatigue is very common. I think the world is under a tremendous amount of fatigue at this time, but I think even treatments bring in fatigue, and being anemic can also bring fatigue. Having renal insufficiency brings fatigue. And then really looking at other symptoms. Could it be neuropathy? This numbing and tingling in the fingers or toes. Is this a symptom of the myeloma, or is it a symptom of something else, another disease, possibly diabetes? Treatments from myeloma, that yes, our goal is to kill the myeloma, but we also know they also have symptoms. Drugs all have side effects. So they are myelosuppressive. They can lower your immune system, which puts you at a higher risk for infection. Some drugs like Dr. Costa and Dr. Stadtmauer also said was this peripheral neuropathy. We know that proteasome inhibitors can cause peripheral neuropathies, but so can immunomodulators and some of the monoclonal antibodies. Diarrhea can be common, whether it's in sub-Q or an injection into the sub-Q tissue, or if it's an oral chemotherapy, diarrhea can be common, or it can be from an infection. Certain medications can cause deep vein thrombosis or clots, usually in the lower part of our bodies, right? We know that the immunomodulators have a higher risk of causing lower extremity DVTs, and we should be on all some type of prophylactic for that. But again, it is a cause. Having a malignancy or a cancer also increases patients' risk for having clots. So when we talk about things, when you're speaking with your physicians, asking them, should I be on some type of anticoagulation? Should I be hydrating myself? And also, really, one of the best things to do also is exercise, right? Movement helps try to decrease the risk of developing DVTs. And also infections, shingle prophylaxis, right? We've all had chickenpox possibly in our lifetime, but we also know that as we get more mature in age and being on certain therapies, the risk of developing the herpes zoster or the shingle vaccine the shingles infection can be common. Next slide, please. What happens if symptoms are not managed effectively? And I think this is very important. Even us all living in a pandemic, what can happen from different symptoms that may not make us all feel well, the patient themselves? And then remember, your caregiver is there to help you, but it also can affect them in your relationship. So anxiety and depression, right? Anxiety of some of the side effects that you may have, because you are anticipating that it's not going to make you feel well, or even depression because you may develop pain or neuropathy. We feel depressed. We might social isolate. And I think somebody brought up a very good question about the COVID vaccine. Isolation, the pandemic all put us into a small bubble, but being on chemotherapy does not mean to isolate ourselves. My biggest thing is be mindful, know your environment. If you know that your friends or family are vaccinated and everybody can be safe, then be social, see them. Don't miss doses. And this is a big thing. I have a lot of conversations with my patients and caregivers. If you don't feel well, then you come and see me. I think that's important. Letting me know your symptoms is higher priority than just saying, I don't feel well, I'm not going to come in. Because then we need to assess and see how we can make this less of an effect or side effects. And honestly, quality of life. I think that's the most important thing. Everybody wants a work-life balance, and I think we need to come up with a treatment-life balance in the world of myeloma treatments. Really, how do we balance what your quality of life, what your goals are, and how to keep you on good therapy? And I'd say, like I said earlier, really discuss everything with your care team. Be very honest and open. Share with us. That's why we're here for you, to be that person for you and help guide you. Express if you feel common fatigues and treatments from other priorities. Next slide, please. So, like and you saw in the clinical trials and on the slide that showed all the combinations, steroids is a side effect is really the foundation of most of our myeloma treatments. Steroids are in part of it, whether it's dexamethasone, whether it's methylprednisone, whether it's prednisone, there's always a steroid involved. And they have side effects, right? Irritable moods, irritability, mood swings, depression. I make a funny joke with my patients. I said, when they're on steroids, either their house is very cleaned or they're living in the garage because they were irritable. Things occur. We know it excites people. There's difficulty sleeping and insomnia. The days that they get steroids and maybe a day or two, they can't sleep. They're up all night. Increasing risk for infections, right? It can be immunosuppressive. We know that steroids can affect our vision, development of cataracts. So having frequent eye exams are important while on treatment. We sometimes get heartburn, or we may gain weight because there's water retention, or it also irritates the stomach. So again, understanding these side effects, we have means to try to decrease them. Let us know. It will increase. If you have a history of diabetes or high blood sugar, then tell us up front. Let us know who your endocrinologist or who your care provider is who's managing your blood sugars, because steroids will elevate your blood sugar while on them. So we may have to come up with a regimen where on the days you're on steroids, we may have to intervene a little bit stronger. And then when you're off your steroids, how to dose reduce it so that your sugars don't drop too low. We know that it will increase your blood pressure. But again, knowing who your support teams are, your cardiologist, helps us be able to manage your symptoms. I think steroids, take with food, they can irritate the stomach tremendously. So have breakfast, then take your steroids, right? Stomach discomfort, there are over-the-counter drugs out there. There are PPIs or H2 antagonists, histamine antagonists that can help reduce some of the gastric acid in your stomach for that GERD or heartburn or indigestion. I'm Italian, so we call it agita all the time. So, you don't want that. So really, it does help kill myeloma, but I also don't want you to feel your quality of life is less. Next slide, please. Fatigue, depression, and anxiety. I think this is one of the most important things to have an open conversation. It all can affect the quality of life and relationships to yourself and to your family or your support group. So how do we manage that? And I think, some of this is sometimes people say, well, it's common knowledge, but I think, it's hard when you're depressed. Sometimes we don't want to go out or we don't want to socialize, but getting outside, walking around, I know we're still very concerned about the pandemic and with the COVID virus, but, wearing a mask and going out and walking around the block a few times is very healthy. Getting proper rest. And I mentioned earlier, steroids can interfere that, and figuring out with your care team how you can manage that steroid insomnia, but making sure that you're getting the best sleep and then up at times when you need to be properly up. I think support groups are wonderful. I think the IMF provides a tremendous resources of whether they're in person or virtual or just having a conversation with somebody on the phone. So social and network support groups are extremely important. I know some people don't like to FaceTime or look at people and say, I have this concern or question, but I think FaceTime has really, or Zoom and all these other virtual ways of discussing things has really helped some of this fatigue and depression in the pandemic, because you can still see your grandkids or your children and talk to them and not be isolated or get them on the phone. Looking at spiritual support is important. Reaching out to your spiritual guidance can help through that. And there are other medications that can also help depression and fatigue and anxiety. I think massages are important. It's okay to get a massage with, I would ask your care providers how the type of massages are, because there's many different styles of massages, but having that mindful touch during a massage, I think is extremely important. So having a massage, ginseng, and sometimes because of anemia and fatigue, getting a transfusion also may help you. Next slide, please. We've talked about immunosuppression throughout this entire program, and it's true. Infection prevention and treatment is extremely important. It's important to tell your healthcare team if you have a temperature or a fever greater than 100.4, and if with shaking, chills, or even without a fever, shortness of breath, it is an emergency. You want to either call your healthcare providers, or you, depending on where you are in your treatments, go to your nearest clinic if they have an outpatient clinic overnight, see them, or need to go to the ED, because it is an emergency for infection, because we are immunocompromised. But how do we as a team together try to prevent some of these? So good, hygiene, skin, oral hygiene, steroids and chemotherapies can affect our dental. So having checkups every 6 months, making sure you don't have cavities, or making sure the gums are properly taken care of. Knowing, washing your hands, don't, if somebody says, oh, I've had a cold or my child's sick, then don't go and visit them at that time. FaceTime them, talk to them, try to avoid contact with people who feel like they may have some type of illness. Sometimes in your therapy, and I think some of you have experienced this, that you may have low white blood cells or neutropenia. So there are medications out there, Neupogen or filgrastim, that can help boost white blood cells to try to prevent infection. We talked about immunizations. I think that was an important topic with the COVID vaccine, but we do need to be properly immunized, but all vaccines should be not live. So no live vaccines, but making sure you have your pneumococcal 13 and 23, knowing that you're getting your influenza vaccine yearly, having that COVID vaccine, making sure after transplant, you're getting the proper vaccines 1 year post-transplant. And again, staying on those antiviral medication. So antivirals to protect you from shingles. You can have antibacterial. Sometimes if your white count goes too low, we may intervene and give you prophylactic antibiotics to help protect you, whether it's levofloxacin or other medications that are out there. Next slide, please. Pain is important. We know that pain or bone lesions is one of the symptoms of myeloma, but also sometimes treatment may also cause it. We talked about the proteasome inhibitors that can cause that numbing or tingling or burning sensations that can be painful. It can induce, sometimes pain is depressing and cause anxiety, and it really does compromise our quality of life. So really understanding where the source of the pain is coming from. Is it from a bone? Do I need to see an orthopedic or refer you to an orthopedic to make sure that you are being properly taken care of, or give some bone supportive care? Or if it's neuropathy, are there medications that I can help to try to reduce this burning, tingling, or may I have to modify some of your treatments to help reduce some of that? Bone strengtheners are out there. The bisphosphonates are also there. But after proper dental clearance, you should be on some type of bone strengthener to help prevent bone fractures over time. So it's important. Again, I think the major topic here is really communicating with your team about all your symptoms and understanding that we can try to help modify and keep you on therapy. Next slide, please. So I am so blessed that I had this conversation with you all. And I think what's really important and what our message is really saying today is really be the empowered person in your treatment. You are really the captain of your wheelhouse. You help us guide you. Let us know where you want to go, and we will try to get you there to the best of our knowledge. But really, I would say the most important thing is really go to the IMF website for all the information that's available. And I want to thank everybody for this opportunity that I had to talk to you today.
Well, Daniel, you're very excited.
Always.
Well, that's great. I really appreciate your presentation today. I think we've had some Star Wars people, some, really, the constellation of factors in your team. You always have, you're the captain. It's fantastic information. Listen, we got a few minutes, so I'm going to ask one question and then we'll go to another one. I'm on Dex right now. Do I always have to be on it for the treatment of my combination? I mean, I'm on Dex right now.
So I'm good. So it depends. I will say dexamethasone or steroids really, like I said earlier, was a backbone of, killing myeloma cells. But we have learned through over time that, it depends on where you are in your treatment and the depth of your treatment, that eventually steroids can be removed over time. Sometimes in maintenance therapy, steroids are not used. And sometimes I think from my personal practice, patients that are on what do you call it? I just totally went somewhere else. Thank you. A monoclonal antibody for a long period of time, I actually start to pull the steroids out.
I see. All right. And Dr. Costa, we have a question. How do you recruit people for these clinical trials that you're doing or studies?
Well, that's a important and big question. I really like, I'm a clinical investigator. I spend my time seeing patients. I think of my clinic as my laboratory in a good way. I think clinical trials are a win-win for everybody. I think the very best way I can help my patient is by bringing innovative treatments. And I think what I find most sometimes surprising and heartwarming is when you spend the time and explain to the patients why the trial is being done and why that's important. They will join your mission. They will understand why that's important for them and why that's important for the field. The challenges really are getting the people in front of you. Are the patients you don't see, the people who are never get to be in front of an academic investigator. And I think that's why it's important that you always, as a patient, you always, ask for a second opinion and always bring up clinical trial on your own. even if your doctor doesn't at the time of a treatment decision.
Perfect. Okay, that's
Ed, how do you do?
Ed.
Well, yeah. Well, the way I think about it, I mean, I agree completely with what Luciano said. The way I think about it is every time there's a change in the patient's disease, a progression or something, whenever I sit down with the patient, I talk about all of the options, and including whatever clinical trials that I have available or present. And so I see a clinical trial as just expanding my clinical options for the patient. So you almost always, I'm not putting a patient on a study for the experimental aspect of it. I'm putting them on because I believe that the participation in that trial is the best care for that patient. So I see it that way. And virtually when we get through that, or when you go through that thought process, when you have the best interest of the patient at heart, we usually make the right decisions.
I see. All right. Dr. Sam somewhere said, how do you characterize renal dysfunction? Anyone want to take that?
Well, the number one test that we do is a blood test called the creatinine. And what I always tell the patients is the number 1 is normal. The number 6 is so bad that you need dialysis. And so you monitor that as one of the, it's not the only test, but that's one of the more important tests of how well the kidneys are functioning. And so if that number starts creeping up, then you start thinking maybe either the disease or the treatment is causing a problem, and you start having assessments for that. It's very important for many of our patients, particularly those with renal problems, is to also have a collaboration with a nephrologist, with a kidney specialist who can keep an eye with us or is available should there be changes that we need help with.
Okay. An email just came in. Will mRNA technology help advance research in myeloma? mRNA, it might be just RNA. I can't read the thing here. Go ahead and take that, anyone? Maybe they're asking the wrong question. Okay, we'll pass on that one. Jack Aiello had a question. Where is that? Dr. C, can you talk a little bit about the MASTER trial?
Sure, yeah, that's a trial for newly diagnosed patients where patients receive quadruple therapy, followed by autologous transplant, followed by additional cycles of quadruple therapy. And MRD was evaluated at each phase of the therapy. And for patients who have MRD negativity in 2 consecutive assessments, we then discontinue therapy without maintenance and observe those patients and monitor MRD. So this trial is being reported at ASH this year. That's the final primary endpoint analysis. Wow. I think the good news is, most patients reach MRD negativity, it was like 80%. About 72% of patients had 2 reads and were able to discontinue therapy. But really what we want to know is kind of long-term, how do those patients fare without therapy? With the follow-up that we have, we're presenting, the majority of patients do very well, including the patients who have one high-risk abnormality. But there's a small subset of patients that we call ultra-high risk, which really haven't been represented in most trials because they usually are sick when they come in with renal failure or poor performance status. In this trial, we were able to capture those patients because it allowed 1 cycle therapy before enrollment. And those patients are a challenge. We had 24 of those patients on this study. And some of those, 4 of those actually progressed while on quadruple therapy. So I think that if nothing else, I think this trial highlights one thing that I think is overdue in myeloma is to stop trying to answer trying to have universal answers to myeloma. So it's clearly there are some patients that are going to do very well. And maybe a good approach is an intensive upfront therapy followed by no maintenance, and people love not to be on therapy forever. But there's the other extreme people for whom even quadruple therapy is not a solution, and those are people we should consider for trials incorporating perhaps CAR T or bispecific early ons. I invite you guys to look at, watch out for those results at ASH in 5 weeks.
Well, let's see, 5 weeks, 19 days to Thanksgiving. How's that make you guys feel?
Hungry?
Hungry, yes. I had a feeling you were gonna say that, Daniel. Makes me feel hungry too. Well, listen, everyone that spoke on our panel today, thank you so much, Daniel and Luciano and Edward. You guys knocked it out of the ballpark, as they say. And thank you for taking all the questions. I'm sorry we went a little bit over, but it happens. And for you people that are out there, make sure you know that Amgen, Bristol, Myers Squibb, GSK, Janssen, Karyopharm, Oncopeptides, and Takeda sponsored this wonderful workshop. And it's important for you to fill out the forms after it. And then remember that this is available to you after the presentation today. So if you missed something, go back to that and take a look at it on your own time, especially if it's late at night and you're on steroids, you'll be able to get through it. Thank you, everyone. Have a wonderful day. And if I don't hear from you before, good Thanksgiving. Bye-bye.
You did.